Welcome to the next Parkinson's Pointers lecture. The talk today will be on Parkinson's and hospitalization. We'd like to thank very much Abbott, our sponsor, for making this possible tonight. Thank you. So my name is Stephen Grill. I am a member of the board of the PFNCA and the director of the Parkinson's and Movement Disorder Center of Maryland. We are broadcasting from my office here in Elkridge, Maryland. And we'll get started. First, want to mention that I have no competing interests here. I have no conflicts of interest for anything I'll be talking about tonight. Okay, so we're going to talk about hospitalization in Parkinson's. Unfortunately, hospitalizations are more common in Parkinson's than the general population by about 1.5 times. I would submit that many of these hospitalizations are preventable. And there are things that I'm going to suggest for you to do to try to prevent some of the hospitalizations. But once hospitalized, there are very specific hospital challenges for people in Parkinson's, and we're going to talk about that. I'm going to admit that hospitals and physicians need to improve in how we manage people with Parkinson's when they're admitted to the hospital. But really, a lot of what we're going to talk about today is measures that you can take to reduce the risk of hospitalizations. Now, throughout the talk, you'll see these check marks come up, and these are action points. These are things that I'm going to suggest that you do to try to make things go smoother. Also, throughout the talk, you'll see hospitals displayed from the Baltimore, Washington, Virginia area, and these are some of your local hospitals. When you see your hospital come up, give a bit of a cheer, because these are important places. Even though we want to avoid going to them, they are places where people get help. And we're very fortunate in this area to have excellent hospitals to choose from. Okay, let's first talk about what the reasons are for hospital admissions in Parkinson's. And we can sort of break these into direct disease-related problems, indirect disease, and non-Parkinson's related. So the direct disease ones have to do with your maybe medication schedules, the motor complications from taking your medicines, for example. Another big category is psychiatric symptoms, so people with cognitive problems or psychotic features. This becomes a big challenge in the hospital. The autonomic nervous system problems that are a part of Parkinson's, such as the low blood pressure, bowel and bladder problems, these come up, and these can cause people to get admitted to the hospital. And finally, side effects of various medicines that we use to treat your disease can lead to hospitalizations. The indirect disease-related causes include trauma. People with Parkinson's are more likely to fall and break bones, and also some infections, especially pneumonia. People can choke on can have problems swallowing and can choke on food, and that can cause aspiration pneumonias. But the reality of it is that most Parkinson's patients who get admitted to the hospital are admitted for non-Parkinson's related causes, for other diseases, and we'll talk about that too. But there is a challenge, even when you're admitted for something other than Parkinson's disease, there's a challenge in managing your Parkinson's in the hospital. Okay, so let's go over the reasons for hospital admissions in Parkinson's. This was a large study, and this was admissions to a general ward. This was a literature review from studies over the last 20 years. And what we find is that patients with Parkinson's are 1.4 times more likely to be admitted to the hospital. But most of the hospitalizations were related to comorbid conditions. Comorbid meaning other illnesses other than Parkinson's. In Parkinson's, the increased risk for hospitalization results from aspiration pneumonias, psychotic features, hallucinations and delusions, bone breaks such as hip fractures, urinary infections, and other systemic infections. And you can see that in the patients that were admitted to the general ward, that about 30% of them were admitted for falls, and about 15% were directly related to Parkinson's, but the other were for other reasons. So most of the admissions were for other reasons than Parkinson's. And if you look at the reasons patients are admitted to neurology, it's a bit of a contrast. It's more related directly to the Parkinson's. People admitted to a neurology ward may be admitted for motor complications, for the psychiatric problems, and then falls and other infections as well. Okay, and let's look a little bit more. This is another study. This is a case control study, means they looked at 590 patients with age-matched controls, and they looked at what caused their admission. And again, in Parkinson's, patients that were admitted, it was comorbid disorders, other illnesses that generally led to the admission. One thing that's nice is that people with Parkinson's their hospital stays weren't really much longer than their peers, and also the mortality rate was not increased for people with Parkinson's. Let's look a little bit closer at this slide, and you can see that about, and so blue is for boys, red is for girls, and the dark bars are for people with Parkinson's. And you can see that fractures, fractures from trauma is more common in Parkinson's, and even in women more common than men. Pneumonia is more common. Urological disorder, bladder problems, neuropsychiatric problems are more common in Parkinson's. And but if you look over to the right, what should be nice to hear is that people with Parkinson's, and we've talked about this in prior lectures, have less of a risk for heart disease and stroke in general. And also there may be a little bit less risk of some of the cancers. So that's nice to see. But again, what you see is that there are some admissions directly related to the Parkinson's, but more often it may be unrelated directly to their disease. So what are the risk factors? Who's at risk? This is one study that looked at a couple of things. They looked at 3,400 patients with Parkinson's, and 31% of them had an encounter, meaning that they were either evaluated in an emergency room or admitted to the hospital. So the risk factors in this study were longer timed up and go. That's what that is it's sitting in a chair, walking, and coming back and sitting down. So people that walked slower and had trouble getting up from chairs had a higher risk of admission. More comorbidities, more other illnesses. That makes a lot of sense, right? And people with motor fluctuations were more likely to be admitted. And then people with deep brain stimulators have a higher risk, too. We're going to get to that later, too, that people admitted with deep brain stimulators have their own challenges when admitted. Okay, so this is a systemic review of interventions to reduce hospitalizations. So how can we reduce? What can we do to reduce the hospitalizations? One important thing is regular neurologist involvement. So patients that saw their neurologist on a regular basis, I usually see my patients at about 3-month intervals, had a less risk of going to the hospital. The next thing was something very interesting, an open access clinic. What does this mean? This means that if you feel like you need to be seen, you just come on into the clinic and we're waiting here to see you. This is hard to do in the real world. It's hard to do in an academic setting. It's hard to do in a private practice setting. And also, there are some caveats about this. So if you call our office and we're not sure whether you should go to the emergency room or come to our office, we often will err on the side of going to the emergency room, because if it is a true emergency and you come to our office, you might waste a couple of hours, getting to our office first and then getting to the emergency room. So even though this study is very interesting, having an open access clinic is a hard thing to achieve. Now, the other big thing, though, in terms of reducing the risk for hospitalization is Parkinson's medication adherence. So if you're 80% compliant with taking your medicines regularly, that also reduces your hospitalization risk and your ER visits. So that's something that you can do to reduce your risk. Okay, so again, summarizing PD-specific hospitalization prevention, fall prevention is very important because that's a lot of the reasons for admissions. So physical therapy and assistive devices should be used when indicated. Infection prevention. If you're choking, let us know about it. We can help with that. We manage the bladder symptoms, and then the PD medication issues, frequent medicine assessment. So show up for your appointment, see your specialist, see your neurologist on a regular basis. And if we target these problems, not only do we avoid the hospitalizations, but your overall quality of life is better. So let's look at the falls. So this is just a study looking at the frequency of falls. And what you can see is that half the people with Parkinson's were considered fallers, meaning they fell 1 or 2 times per year. But a quarter of them, these ones in the pink and the red, needed treatment. They're the ones that needed the hospitalization. Some of them needed surgery. And again, I think if you pay attention to avoiding falls, we can avoid this really horrible situation. And then also, if you're at risk for pneumonia, if you're choking on food, you should let us know. You should tell your physician, and then we will usually have you evaluated by a speech-language pathologist, swallowing pathologist, or specialist, and often do a modified barium swallow, which you see on the slide. And what this can do is it can assess whether you're moving the food around right in your mouth and whether it's going down the right place, whether it's not, it shouldn't be going into your lungs, it shouldn't be going into your windpipe. And they can see this on the modified barium swallow. And then if there's a problem, you can have swallowing therapy. And you can, and they can suggest various consistency foods that might be better for you to eat. And if you're choking on your saliva, we can also help with that. So we can use sublingual atropine drops right under the tongue. It works on the salivary glands in the mouth to dry up and slow down the saliva flow. And if that's not helpful, we can also use botulinum toxin injections right into the salivary glands to reduce the salivary flow. Okay, so let's get to some action points. Number one, avoid falls. You know, I know this is stressed time and time again at our symposia. Falls can be game changers. So be compliant with physical therapy and the use of canes and walkers. Reduce your risk of infections. If you're choking, let us know. We can help with that. And then good regulation of your Parkinson's meds, regular visits with your neurologist. Okay, but we can't always avoid hospitalization. And so what I'm suggesting is you should plan ahead for hospitalizations. You should think about it before you're hospitalized, what you want to do. And one of these things, well, a few of these are listed here. One is to pack a ready bag. Pack a bag that you're going to have ready, and if you're thinking you're going to the emergency room, then you know it's there, and you bring it with you. Another main thing is to facilitate communication. You want your outside physicians to communicate with the hospital physicians. We want to know when you're admitted, and when you're discharged, you should arrange to have your hospital records faxed to us. Having family and friends support while you're hospitalized is important, especially for people with cognitive problems or dementia or psychotic features, because those usually get worse when you're in the hospital. So having support around is very important. And then there's another issue with a specific class of medicines, the MAO-B inhibitors like rasagiline, Azilect, or selegiline, sulfonamide. These are medicines that have a theoretical interaction with some medicines that might be used after surgery, some opiate analgesic medicines if you're in pain. So most physicians recommend that you stop these MAO inhibitors 2 weeks before elective surgery. And if you're admitted, obviously you're going to let them know that you're on one of those medicines. Okay, next action point is packing a ready bag. So what should go in that ready bag? So the first is a medication list, and your medication list should include the exact timing of the carbidopa-levodopa. When physicians write orders in the hospital, and we say BID or TID, so BID means twice a day, TID means 3 times a day, but it doesn't specify the time. And it could be something like, 9, noon, and midnight, for all we know. So you want your medicines at a certain time. You should include that in your medication list and communicate that to the admitting people, to the physicians and the nurses. You should also have a physician list with you, the physicians you want the hospital to communicate with. If you have a living will, and you should, advance directives, that should be included in this ready bag. And finally, other legal documents such as power of attorney or guardian documents should be included. And these first 4 things, you can pack now. You can pack today or tonight. The National Parkinson's Foundation had this ready bag. I don't know that they still do. We're trying to have the PFNCA make our own one that we would tailor to your needs. Bring your branded medicines. So if you're on some of the newer medicines like Ritari or Gocovri, then they may not be on formulary in the hospital. But if you bring them with you, you can give them to the pharmacist, and they'll administer them in the hospital. And then you can be on the same medication regimen that you are on as an outpatient. Bring your eyeglasses and hearing aids. You're going to need to give a history to the physicians and nurses. You're going to need to communicate. You may need to sign documents. Bring your hearing aids, bring your eyeglasses. And then finally, if you have deep brain stimulation, you should bring your control devices. There'll be circumstances during the hospitalization where you'll need to turn it off. If you're having an EKG, for example, that would interfere, your DBS system might interfere with the signal, and for procedures, any surgical procedures, the stimulator is turned off. So bring that with you. If you have a rechargeable battery, you need to bring the recharging apparatus with you so that you can be recharged while you're in the hospital. Excuse me. I give my patients a form like this for them to bring, and it gives them some information. It gives the staff some information about Parkinson's. It gives the medications. It asks them to contact me if they're thinking of changing your Parkinson's medicines. And it also gives some information about some of the problems that you might be admitted for, and how they should evaluate that. So I had a patient once who they were admitting from the emergency room because his walking was so much worse and he couldn't walk. And so I asked the doc, what's his walking like? Because last time I saw him, he was pretty good. And they said, well, we didn't get him up and walk. So they should have, a little bit condescending, but I want them to evaluate your walking if that's what you're admitted for. Okay, let's turn to some of the challenges in Parkinson's when you're admitted. We'll go through this again. So the first is medication issues. So timing or lack of administration of the medicines you're on is often a problem. Contraindicated drugs that cause Parkinson's to get worse, dopamine blocking agents. And then also non-formulary medicines like we talked about, you're going to want to bring with you so that you can stay on your regular medicines. The staff and nurses may be sort of unfamiliar with Parkinson's disease and the medications. They might not understand what freezing is. They may get frustrated when they're trying to get you to walk one place to the other and you can't. So they may not understand these issues. And that's something that us movement specialists really need to work with, to have in-services in the hospital to work with them on that. Psychiatric disorders can be triggered or exacerbated by admission. So we're now on to the hospital environment issues. You should expect that will happen, and we'll talk more about that in a bit. And then complications due to immobilization. You get laid up in the hospital for a few days, you're stiff, you need to get going, you need to mobilize, you need to maybe have physical therapy work with you for some time to get you going. And then there's something that I call competing interests. When you're admitted, you may not be admitted for Parkinson's, you may be admitted for something else, and something that those other specialists or medical doctors are doing could affect your Parkinson's in an adverse way. And we'll talk a bit about that. And then there are these special considerations if you have deep brain stimulators and a Duopa pump. Okay, but let's turn to the literature on what it says happens in the hospital. So in 74% of admissions, the Parkinson's disease medicine was stopped, omitted, or wrongly prescribed. I had a patient a couple of years ago who was admitted. He was on ropinirole ER, the long-acting version of it, and he was on a pretty good dose of it. And when he was admitted to the hospital, they didn't even take note that there was a long-acting ropinirole ER. So they gave him the equivalent dose of the regular medicine all in the morning, all at once. And instead of the long-acting medicine, which was slowly released over 24 hours. So I got called that every morning they would give him his medicine. He would be snowed out. He'd be sleeping the whole time. And then he would wake up in mid-afternoon, and all his Parkinson's symptoms would be back. And so this was a real error that caused him to be in the hospital for 3 days because they were giving him a whole big whopping dose of the short-acting medication instead of the same dose spread out over 24 hours. Okay, non-adherence to medication schedules. We understand that when you're in a hospital, they're not going to be able to get you your medicine exactly on time like you do, but we try to get them to be close. But that's a problem in hospitalizations. Anti-dopaminergic medicines were prescribed in 11% of patients. Medicines that block dopamine cause Parkinson's to be worse. We try to avoid that. And then postoperative problems were pretty common and increased in people with Parkinson's, particularly the confusion and delirium postoperatively, up to 60%. So that's something that hospitals really need to be attuned to and really need to react to when it develops, and we shouldn't be waiting days to be able to manage that sort of thing. Okay, let's turn to the medication interactions I was talking about. So some medicines that are prescribed in the hospital may not be compatible with Parkinson's. So antipsychotic medicines, the classic ones, and even the newer ones like Zyprexa, olanzapine, risperidone, they make Parkinson's worse because they block dopamine receptors. So the antipsychotic medicines that we use in Parkinson's include Seroquel, quetiapine, Nuplacid, the new one that's indicated for Parkinson's psychosis, and then clozapine is another one we sometimes use. It's a very good antipsychotic medicine, but it can affect the blood counts, and so we have to be careful about that. Anti-nausea medicines also block dopamine receptors, Reglan and Compazine. These are medicines that, people get nausea in the hospital. They may get prescribed one of these medicines, and it can exacerbate their Parkinson's. And then the other major medication interaction to be concerned about are the MAO inhibitors. And let me say that, there's only a few classes of medicines that are really problems in Parkinson's. Other medicines have tons of interactions, but, it's not quite as bad in the Parkinson's scene, but it's these dopamine blocking agents, and then the MAO inhibitors. So the MAO inhibitors are adjuncts. They help dopamine last longer in the brain. Selegiline, Bisagiline, Azilect are the ones that we use. And there can be potentially serious interactions with other medicines. Now, the MAOA inhibitors are a different class, and they're rarely used, and they would be contraindicated for sure. But what can happen with these MAO inhibitors is that there can be an interaction with certain medicines, including some antidepressants potentially, but also with opiate analgesics that might be used for pain control. So most physicians think that we really should just never use them together. It's rare to have a real problem, but you can get something called serotonin syndrome, which is life-threatening. So make sure that the physicians and the staff know if you're on one of these MAO inhibitors and to try to avoid medication interactions. So that's one of the action points. Again, we recommend that you stop these MAO inhibitors if you're on them 2 weeks before elective surgery, and just ensure that the medical team knows that you're on one of them once you're admitted. Okay, let's move on a little bit to some of the acute problems that happen in hospitalizations. This is a study that looked at this, and so they looked at comorbid problems that developed while they're in the hospital. So patients admitted to neurology will be at a higher risk of subsequently developing a pneumonia, having diarrhea, urinary infections, and patients admitted to non-neurology, also similar, getting infections, can get agitated, that sort of thing. And the agitation that happens in the hospital is something that we really all need to be prepared for. So there's something called hospital-induced delirium. Patients with cognitive impairments or dementia, or with psychotic features, with hallucinations and delusions, we should assume that they're going to get worse once hospitalized. Benign hallucinations, where you may see, a spider crawling and you sort of know it's not real. If you have those, we should assume that that's going to get worse while you're hospitalized. And the reasons for that is that you're in an unfamiliar environment. Look at the lady in the picture. Look at that room. Is it night or day? You can't tell, can you? And neither can she. So the day-night cycle is all thrown off when you're in the ICU, or even, in different parts of the hospital. You're immobilized. You're like tied down, maybe, or you have tubes coming in, some coming out, in some cases, and you're really immobilized, and that can be very confusing to people. You're often given sedatives and pain medications. That makes you goofy. The sleep in the hospital. Has anybody had a good night's sleep in the hospital? There are nurses coming in and out. There are noises in the hallway. Your heart monitor is beeping. It's very hard to sleep. You can develop electrolyte abnormalities because you're not eating the way you normally eat, or you may be not able to eat parts of the day because you're having a test. And then you can develop hospital-acquired infections. So all of this contributes to the delirium that can happen in the hospital. And, we manage this. We have to be able to manage it. And there are things that we can do to minimize it, and there are things that you can do to minimize it, and we're going to go through that as well. And finally, one of the other categories was the competing interests we talked about, what happens in the hospital. So nobody just has Parkinson's. Very few people just have Parkinson's. People have other diseases. And so management of one disease may exacerbate the symptoms of the other disease. For example, in treating in heart disease or in treating hypertension, people with Parkinson's generally develop low blood pressure. And orthostatic hypotension means a drop in the blood pressure when you stand. So normally when you stand, the blood rushes to your abdomen and to your legs. The veins have to clamp down to push it up to the brain. And that mechanism is a bit impaired in Parkinson's. So you're more susceptible to low blood pressure problems. But cardiologists in the hospital like to use beta blockers if you have coronary artery disease, if you've had a heart attack. These lower blood pressure. So this is an example of competing interest, and this is a reason that we need good communication. All the specialists that see you in the hospital should be competing. If you have an outside cardiologist, we might ask for their assistance. Communication is important to address these competing interests. Okay, so how can we improve the care for the hospitalized patient? There's no really good studies, but there are some recommendations. So one is that we really take a multidisciplinary approach. We communicate, the physicians communicate. We should try as hard as possible to maintain the exact medication regimen, and you should encourage that and ask for that. We, as specialists, need to do a better job of educating physicians and nurses in the hospital, and they should be attentive to early signs of complications. Fall prevention is obviously important. Emotional support is important, and your family being there for you is a great thing. Attention to trying to let people sleep, very hard to do in the hospital. Ensuring good nutrition. Limit the number. For somebody with cognitive problems, it's much better if you can have one or two nurses that spend most of the time with you so you don't have to deal with a whole bunch of different people. And then how can we improve perioperative care after you've had surgery? So during the preoperative screening, they should be evaluating your cognitive functioning, your respiratory functioning, all of that, and taking that into account. Around the time of the surgery, we should try to continue your Parkinson's meds close to the regular schedule. It's a challenge in Parkinson's if you're not allowed to eat for a time. We have a rotigotine patch, which is a dopamine agonist patch. We have an enteral suspension, the Duopa pump, but that's hard to sort of initiate in the hospital unless it's a prolonged hospitalization. So it's hard when you can't take your Parkinson's meds. If you're having surgery, if the surgeon would consider local anesthesia, it might be better tolerated. Okay, action points. Again, give your hospital staff branded medicines that you have. Make sure that you can stay on your regular medicines. Give them an ER list. Make sure from the beginning that the meds are ordered correctly. Mobilize early. So if you're in bed for a week, it's going to be hard to get out of bed. So ask to get out of bed when allowed, to at least get to a chair and be able to sit in a chair. And then physical therapists can work with you, and they should if you've been in there a few days. Ask that, can a physical therapist help get me back to walking as well as I was before I was in the hospital? And the hospital staff is always happy to do that. It's often neglected. But that's something you can remind them and say, hey, do you think physical therapy would help for a couple of days while he's still recovering from this illness? A support system. This is especially important for people with cognitive decline or dementia. And the things that you as family can do for your loved one are to keep the room well lit during the day and close the blinds at night. Give them a day-night cycle that they can follow. And having family and friends present is much better than to calm people down and keep them from being agitated than having to give a sedative, which makes us goofy. And then if somebody is getting agitated, consider an overnight sitter. And the hospital will often pay for this if they think there's some danger that could happen to the person. But it's a very helpful thing. And again, I've stressed this a bit, facilitate communication with your internist, neurologist, and other physicians throughout the hospitalization. And then discharge planning. So be involved in that. have you bounced back to where you were before the hospital? Most of the time it's not quite. If you really haven't bounced back, then maybe a stay in rehab for a week or two would help. Consider home therapy, a therapist coming in, whether you need an aide for a time after the hospitalization. So there's a case manager at the hospital that can help assess what the needs would be at the home and how long, and they can be involved in helping set that up. Okay, one more point about facilitation. Again, this is you and your team. Make sure that your team knows that you're admitted and have hospital records faxed once you're discharged. Okay. And okay, so let's turn to a couple of special issues. And people with deep brain stimulators. You should bring, again, I talked about this, you should bring your control device with you. Ensure that the medical team knows that you have DBS. There are certain procedures that you can't have done except under special circumstances. Now, diagnostic ultrasounds are okay. If we want to look at your carotid artery or your heart, those are okay. The technician should be aware you have the DBS and avoid coming close to your system. Your DBS needs to be off during various procedures and surgeries. And the companies that make the deep brain stimulator system, they will often be available. They can be available for help with that, making sure that your system is compatible with an MRI, that sort of thing. The MRI compatibility is improving. Currently, Medtronic and Abbott systems are okay, but with some precautions. Okay. And then, again, if you have a rechargeable battery, bring your recharging apparatus. And, usually the family would end up doing it if you're not able to do it. Okay, and then one more special situation, and that is the carbidopa-levodopa intestinal gel, the Duopa pump, which some of you may have. The nursing staff will probably be unfamiliar with the technology. You should bring all your equipment with you. That you can't really fit it all in the ready bag, but you bring it with you in whatever bag you need. And then you should immediately contact Do a Connect, which is available 24/7. And you have the number. You call them. They will educate the staff on care of the pump. And this goes smoothly. So, but these are the things you have to do specific if you have the Duopa pump. Okay, so a summary of the action points. The first one is avoid hospitalizations, and we went over a bunch of ways that I think you can do that you can avoid these hospitalizations. The second is pack that ready bag. Pack it now. Put the things that you can put in it now in it, and remember to bring the specialized equipment. Bring your branded medications. Pack all your legal documents. Really get that ready. And again, you should have a sheet that was handed out to you with all these ready points, and you can look through that checklist. Tell the ER doc and the staff about your medication regimen. Again, make sure that your medicines are ordered correctly from the start. Mobilize early. Get out of bed when allowed. Don't get out of bed if you're not allowed. And ask for physical therapy if it's appropriate. Have a good support system in the hospital. And finally, the other point that we've stressed a lot is to facilitate communication with your internist and your neurologist. They should know of your admission, arrange for the hospital records to be sent. So this sheet, or something similar to it, should be at most of the locations, or if you registered for this meeting, then it was emailed to you. And I encourage you to go through that sheet and see what's appropriate for you. I think most of it is appropriate for most people. Okay, so if you do these action points, and then hopefully your hospitalization will go as smoothly as possible. And